liver hemangioma resection, fluorescent identification of microhemangioma
session, because it's an interesting novel technique. We'll move on to the next presentation. Another novel technique for mapping and labeling of biopsies during the primary laparoscopy-assisted transanal swab and rectal pull-through for His disease by Dr. Ashok Dayaram.
So the next panelist, and then just to preface it, we will be taking a vote at the end of this for the show of hands in the audience. The next panelists that are going to talk to us about a slightly different topic, and that is a topic that does come up a lot, which is how young is too young. Pediatric obesity surgery should be done at any age. And Dr. Alqahtani, who has again distinguished himself in the field in Riyadh, has, I think, some very strong feelings about age and when it might be appropriate to operate on patients at the younger end of the spectrum. So thank you, Professor Alqahtani.
Thank you so much. Thanks for the IBIG and SAGES for their invitation. Definitely, I'll have you for this part. Nothing to disclose. Why should we consider bariatric surgery in pre-adolescent obesity? If we look to these numbers, it's really important to consider those 6 to 11 years of age, up to 20% really obese, and 4% is extremely obese. We are depending on percentile. But this is some serious problems, not just to watch. It's really increasing over years, and you can quadruple from 1980 to 2004 in the same age group. If you look to this 350 children, the incidence is really, this is the enhanced studies, and this is another studies including a huge number of patients, and again, extremely obese 7% or obese 23%. So we should do something for these kids. We cannot leave them like that. Now, facts, if we leave them like that and we don't help them, as suggested in this maybe today by some of the presenters, significant comorbidities, that they will really result in significant like bad outcome. 80% of health costs in the United States is related to obesity-related problems. And this generation, if we continue as such, they will really outlive their parents, as has been said and mentioned in many reports. And unfortunately, till today, there is no specialized clinical care or behavioral support for these kids. 30% of the population having obesity and this age group, and we don't help them. So, what are available nowadays? Lifestyle changes doesn't work, unfortunately. As you can see, meta-analysis, randomized, there is nothing, doesn't work. Drugs, doesn't work. Particularly below 12 years of age, there is no approved drugs to be utilized. So nothing there. Coming to an important figure here, 35% of children going to foster care, less than 5 years of age, became obese or overweight. It's really a major issue. So we have to have a solution. Bariatric surgery, yes, it's a solution. Yes, and sure, there are some concern. And this concern is about safety, about what have been discussed this morning in the meeting. But look, for example, we are debating for sleeve gastrectomy. Sleeve gastrectomy or gastrectomy in general in children is not a new idea. Since 1965, there is a survey that has been conducted in pediatric surgeons who are doing gastrectomy for GI indication below 12 years of age. Look to their conclusion. The most striking finding is consistently normal growth and development. So this is since 1965, nothing new. Now, given the choices, what are the choices? I think we can answer the question, yes, we recommend surgery in this age group, but there are some conditions. Performed by qualified, experienced pediatric surgeon in a committed, adequately resourced institution. They are really committed to the program, and there should be a clear clinical pathway, and this is very important. This is the pathway we follow up on, and we developed and follow in our clinic. This is outpatient pathway. Those who are eligible for surgery they will go to pediatric bariatric surgery clinical pathway. Specific, written, clear, what should be done with these cases. Additionally, there should be a clear follow-up and long-term follow-up. And as suggested by McKelsey, 75% at 5 years should be the aim for the follow-up. Now, in addition to that, the clear criteria should be very obvious and set clearly for everybody. Now, we think BMI itself is not the best option to use for indicating surgery or suggesting patients for surgery. We think percentile is more accurate. There are patients, and the percentile recommended 99 percentile. There are patients with BMI more than 40, and they have severe comorbidity. I'll show you some examples, and we cannot and we should not deny them the treatment at any age and based on their age. We should not do that. So what we know now about bariatric surgery in children below 14 years of age? Case reports, our experience that Tom has mentioned some of it, but what we can see here, 47 patients in this group are less than 14 years of age. Now, this is the outcome. Excess BMI loss is not different, less than 14 or more than 14 years of age, even not significantly different than adult at 12 months and 6 months. Look to comorbidities in these cases. Do we want to leave this patient suffering and living with their problems? I don't think so. It is really more, and look up to 50% sleep apnea, diabetes, hypertension, prehypertension, and significant comorbidities. If you leave them, they really will have a significant outcome. And you can see here compared to 14 years of age. We do liver biopsy in all patients who underwent, in this group, underwent sleep gastrectomy. 40%, they have grade 5 liver injury related to fatty liver, and this is corresponding to NASH criteria. So really, 40% they have NASH. And 12% they will have bridging fibrosis. Look, below 14 is more than those who are more than 14 years of age. Should we leave this patient to go and dying from liver cirrhosis or so in the future? Diabetes, hypertension, sleep apnea, cardiac arrest? It's not the option. So what we can say, yes, sure, we recommend it in this age with specific criteria, with very clear documented indication as we mentioned, and we should specify for each case if it is indicated regardless of the age, and based on the comorbidities, we should not deny the treatment these kids. Thank you.
Now, Dr. Mark Mikowski from Nationwide Children's Hospital in Columbus, Ohio, will come up and tell us why in the world should we deny these poor children less than 14 years of age life-saving surgery and allow them to have cirrhosis.
Thank you. Good morning, everybody, and thank you to Dr. Pratt and Dr. Inge for inviting me. These are my disclosures. I think I'm going to respond initially and fire the first shot and say that I really think we need to step back and use some evidence-based medicine here before we make decisions about how young is too young, or is there an age that's too young to administer bariatric surgery? And really the question becomes, do you actually need to treat this group? And we've heard, I think, some very eloquent data and opinion on what happens in terms of the chronicity of severe childhood onset obesity. And certainly everybody in this room is probably familiar with the concordance between juvenile onset obesity and the development of adult severe obesity. And if we look at the chronology and progression of severe childhood obesity, it really gets started at around age 5. That's really when you start to see the first documented evidence of some severe pathophysiology that leads down the road to a severe level of obesity. And there seems to be a expanding body of evidence that shows this concordance. And if you look at a bunch of 4-year-olds, the probability of developing adult obesity, if you are a severely obese 4-year-old, is about 20%. And obviously that increases quite significantly up to the mid-teens, where that concordance is now up to about 80%. So the question really becomes, what's happening in between that time? What's the probability of a 9-year-old or 8-year-old or 10-year-old developing the type of obesity that's going to carry on into adulthood and go on to have ensuing cumulative disease burden that we all are talking about and quite concerned about? Is there an opportunity, is the window of opportunity to reverse it without something like bariatric surgery there? And in addition, what is the risk of allowing these patients to sit along their trajectory until a more traditional time frame in terms of adolescent morbid obesity surgery? So it really is a risk ratio analysis in terms of when do we operate, when is too soon, when is an appropriate time point. In terms of the concern for age, these references have been mentioned already in terms of the Betsy Lehman series as well as the ASMBS Pediatric Committee Best Practice Guideline. And certainly we're concerned about things like skeletal maturity and Tanner staging. And I think the rest of this talk is really going to focus on the nutritional basis of eligibility for adolescent bariatric surgery and why that's such a concern. Certainly, nobody wants to engage so early that we really put at risk the very, very important nutritional milestones and components that can lead to very, very severe metabolic consequences that really nobody wants to get into. So in terms of trying to understand this and think about it, I think it's important to really look at what the adult data is. We've heard about some of the complications. We know about some of the complications, and I'll go over a little bit of what the complications are in the more traditional adolescent age group. Again, I'm going to touch on some of the pediatric metabolic and nutritional consequences that we really want to avoid, and how that can affect growth, development, and touch on some ethics at the end. In terms of this, like any other evidence-based talk, I think it's important to see what the evidence is, and really there is almost no evidence that doing bariatric surgery in preteens, and I'm going to just arbitrarily define that as age 10 or younger, is a good idea. Recently, Alan Brown wrote an opinion piece on the age and some of the guidelines, and there's no data in here that talks about this age group that I'm speaking about today, but it pointed out some very important things, including the need to have good nutrition for development, vitamin, minerals, macro and micronutrients. It also brings up the issue of medication compliance, which is not great in any child age group, as well as some self-efficacy issues in terms of the ability to comply with dietary choices that would make for a healthy post-operative bariatric patient. And then again, it brought up the issue of ethics. With regards to the meta-analysis that's been mentioned a couple of times here, I do want to point out again that the lap band does have some significant consequences that can have nutritional and metabolic outcomes, including iron deficiency, the gastric bypass complications. This is all adolescents, mind you. There are definitely reports of protein-calorie malnutrition, micronutrient deficiencies, beriberi neuropathy, as well as some severe complications that I'm not going to get into here. But again, remember, this is in the adolescent age group. Why would we expect that this is going to be any better? And I would argue that the consequences might be much, much more severe if we start doing this significantly younger. None of these studies really had any significant data or were built to look at the long-term growth and development. Dr. Inge recently actually published one of the most, really the first paper to look at some of the nutritional micro, macronutrient, and protein compositions of a group of patients undergoing, again, adolescence. And what he showed was, interestingly, that the proportion, even though calorie restriction was achieved, the proportion of protein, fat, and carbohydrates was unchanged, yet the actual amount of protein, calcium, and fiber intake were noted to be well below recommended daily intake. Again, that's a big problem for a bunch of 8 or 9-year-olds. So finally, to wrap up, the risk-benefit ratio, what happens if we let these 8, 9, 10-year-olds progress? Well, as was mentioned by my colleague, development and progression of comorbid disease, absolutely. Significant BMI rise, definitely. Is there a missed opportunity to get to a post-operative BMI that is considered below obese? There is some evidence coming out now that no matter what your starting BMI, you're going to lose a certain amount. A recent reference by Dr. Inge's group showed that only about 14 or 15% of postoperative patients on a broad spectrum of BMI achieved non-obese BMI status after a successful operation. This is compared to the consequence of some very significant and not to be underplayed consequences of nutritional deficiencies in a pre-adolescent age group, including brain dysfunction, cardiac dysfunction, the development of hypertension, and all sorts of other metabolic issues that we cannot ignore. Finally, from an ethics standpoint, we really are treading in very, very weak ethical ground in terms of non-malfeasance. Our obligation to present a very, very reasonable risk-benefit ratio, we don't currently have the ability to do that, as well as issues of consent and assent. In conclusion, I'll wrap up by saying that in the current day, with our current armamentarium of bariatric surgery, it is not appropriate to be doing these operations in a bunch of 8, 9, and 10-year-olds for the risks and concerns that I've mentioned. In the future, however, there are several other technologies on the horizon that may change that paradigm. Thank you very much.
Thanks to both speakers. I think we can take probably one question. We'll have one half-minute for rebuttal. Aayed?
Okay, I will get the slide for rebuttal. Thank you so much. My colleagues already mentioned a lot of points, and he said we need to have, can I have the slide please? We need to have evidence, and we need to have ethical principles. And is it really ethical to leave our patient dying from their diseases? I don't think so. These are the evidence, and we can see the weight loss if we want to compare it to the existing long-term adult outcome. Excess weight loss is identical 3 months, 6 months, and 24 months, exactly identical, 76% excess BMI loss. If you are talking about BMI, absolute BMI, identical at 2 years, and to adult, which we have long-term for these. If we are talking about micronutrient deficiency, baseline and 12 months, there is no difference. In fact, there are improvement for those who can supplement. So again, we have this evidence already to show. We show you some evidence for these cases, like this example of this patient, crippled, wheelchair, obstructive sleep apnea, lung disease, and do we need them to, or should we leave them suffering from their disease on wheelchair? Or should we transfer them so somebody able to walk and go to school? If you see somebody like this, BMI 59, and really crippled, lung disease, wheelchair, sleep apnea, you leave them or you try to help them to be like this. These are the evidence, these are real life, and this is the ethical important issue. If you have some girl arrested a few times from sleep apnea, she is diabetic, and you have her about 2 years later, cured of diabetes, cured of sleep apnea, and no more cardiac arrest. What ethical point in these issues? I think we should be helping our patient to survive and not to be dying in their obesities.
Thank you very much, Aayed. One question from Sam, and we're going to take a quick vote. Sam.
Sorry. So I understand the concerns about the nutritional risks. Obviously, they're very valid, very important, but I have to say there's never been any documented case of growth retardation in any age group, for that matter. I also want to say that I would posit that patients who undergo massive weight loss probably will experience better growth of their skeleton having removed this. But regardless, what I want to ask is, I've operated on 21, 23-year-olds that scratch my head about the decision to do that because of their so-called maturity level. I'd like to ask, what is the scientific basis, if any, of determining a benchmark or a threshold of where we should operate? What is 16 versus 14 versus 12? What is this based on?
Thank you, Samer. That's a great question. I mean, obviously, there's a definite arbitrary nature to deciding when is the appropriate time to operate. But certainly, I think that, again, I would stress that we shouldn't discount the issue of nutritional deficiency. As you know, and as you've alluded to, being severely obese is associated with actual skeletal maturity, early closure of epiphyseal plates, and sexual maturation. So it almost seems like a confusing argument, because in many instances, in fact in the majority of instances, these teenagers are really more developed than their lean counterparts. I think with regards to the earlier age group, there's no question these operations will work and these operations will take weight off. But I think that there are some very, very concerning issues in terms of long-term, longer than 12 months, even longer than 5 years, issues with regards to cognitive ability, test scores, all of those types of things that I think in my mind make this not an urgent issue. There's no such thing as an emergency bariatric surgery, even though I've been called for consults in the past to the PICU. I think we're doing the best we can in terms of trying to figure out what the right age is.
All right, so
just to comment on this, I don't think the age should be the primary factors in deciding surgery. I think it's the comorbidities of these patients. When you have some patients, as we have shown in the slide, who are really suffering from their obesity, cardiac arrest, sleep apnea, other diseases that they cannot live. There is no quality of life. They are on wheelchair. You leave them or you help them. The age should not be the only determinant factor.
Thank you for the entire panel for a great discussion, great debate. And before we dismiss, I do want to get a vote from the audience to see who won this debate. How many people would have changed their mind and would offer gastric bypass now for their teenagers? How many people have changed their mind and would like to offer the band to their teenagers? Sleep gastrectomy for their teenagers. Oh. And how many people would operate on the preteen based on the evidence presented?
Yes, good, see.
Thank you very much.